everyone for coming out today and spending your lunch hour with us. My name is Andy Johnson, and I have had the opportunity to intern with Open Aid Alliance for the last few months, working mostly on PrEP and reaching out to providers and just talking about what y'all would like to have in terms of PrEP training and different things. And so this is one of the events that I've been planning, and really appreciate you all coming out. Just a couple of acknowledgments before we get going with Kim here. A lot of big thanks to Imagination Brewing Company for hosting the event. They've been really great to work with. They're available to sell sodas or beer and wine if you are interested today or any other time. And then also to MCAT for very generously filming this event through a grant so that we can provide it to folks who weren't able to be here today. Really appreciate that as well. And then without further introduction, this is Kim Bailey. She is a registered nurse and communicable disease program coordinator at Riverstone, and has come all the way from Billings to talk to us today. So thanks.
Yeah, well, thanks for having me. And actually, I have some handouts for you. I wasn't sure how many we would need, and so they're little packets, and maybe I know your hands are full. I feel bad. Okay, and there's more here if you need them. So like he said, I'm Kim Bailey, and I'm a registered nurse, and I'm back in Missoula, which was my home, home base, went to school here. So I love being back here. I'm the Communicable Disease Program Manager at Riverstone Health, which is the Yellowstone City County Health Department for Yellowstone County. And then I'm also a trainer, faculty person for I always have trouble saying Mountain West AIDS Education and Training Center. It used to be the Northwest, and so I still want to say that all the time. But so oh, come on. So if you haven't heard of the Mountain West AIDS Education and Training Center, it's based out of the University of Washington in Seattle, and every state is a part of an AETC, and they kind of reconfigured which states we're a part of and made our region quite large. You can see we have a lot of states in the Mountain West AIDS Education Training Center now. And what we're charged to do, we have a grant that allows us to do training for providers and healthcare professionals for AIDS education. And so in order to prove that we're doing what we are supposed to be doing with our grant money, we have some PIF forms that we would like for you to complete. And it asks you to put in a number, and then every time that you get one of the trainings from the AETC, you use that same number, and they don't know who you are, but they can kind of track by your number how many trainings you've attended. So we really appreciate it if you would fill those out, and would also really appreciate it if you would complete the evaluation form. We take them really seriously, and we really like your input on what would be more helpful, what we could do to change to make it more effective if you have any suggestions. So today we're here to talk about PrEP, or pre-exposure prophylaxis for HIV prevention. These are our objectives. We're going to review the definition and the goal of PrEP, discuss the safety and efficacy of PrEP, and talk about who you should consider as candidates for PrEP. And then we'll summarize some of the recommendations for prescribing. So we'll start off with what is PrEP. So PrEP is a way of providing HIV prevention to people who are at high risk of acquiring HIV. They aren't currently infected with HIV, but they're at high risk for contracting it, and by giving them one pill once a day, you can prevent infection. So that's super good. This isn't any kind of a new concept, it's pretty common. The most common example that we use is that of Malarone. When a person is traveling and they're going to be in an area where there's increased risk of contracting malaria, we prescribe Malarone to prevent contracting malaria. So that's what PrEP basically is too. When a person is going to be at considered substantial risk for acquiring HIV, you can prescribe one pill once a day, and it can actually prevent HIV infection. It's important to remember that it is not a standalone method. So it's just one more tool in the toolbox of all of our prevention methods. And so we go all the way from no sex, monogamy, using protection. Viral suppression is also a method of decreasing the chance of transmission of HIV in our HIV positive patients. We use that. Decreasing the number of sexual partners, using safer injection practices, and then Truvada. So all of those are prevention methods for reducing the risk of acquiring HIV. So Truvada is the drug of choice, and it's a single tablet that's taken once a day, and it is proven to prevent HIV infection. But the important take-home message too is that it doesn't prevent any other STDs, and so it's really important to continue to stress the importance of using other methods of protection so that they're protected against other STDs. So Truvada is a combination pill of tenofovir and M-tricytidine. It's one pill once a day. It's been used as HIV treatment in combination with other drugs since 2004, but in 2012 they approved it for use as PrEP. So that was a good thing. This is some data that they were able to collect from 2012 when it was first approved for use through the end of 2015, and you can see what's happened with the number of prescriptions that have been written for PrEP in that time period. They were able to get data from pharmacies that were filling prescriptions, and then they had an algorithm that they used to extract those prescriptions that were written for treatment of HIV infection. So they really wanted just to look at what was being prescribed for PrEP. And so you can see it's been quite an increase, and that only goes through 2015. And so 2016 it increased significantly as well. In 2015, there were about 80,000 prescriptions that had been written for PrEP, and that compared to in 2012, there were about 1,671 prescriptions. And so that's a 738% increase in the use of PrEP over those just from 2012 to 2015. And we really anticipate that it's going to continue to rise as people learn more about it. So this is just a map of the United States, which shows where most of the HIV is in the country, where the high concentrations of HIV positive people are. You can see its rates of HIV diagnoses per 100,000. So these dark colors have really high rates of HIV infection, especially in the southeast there. And so these stars that I've put on here, those are the places that account for most of the PrEP prescriptions that had been written through 2015. So you can see they're kind of New York and San Francisco and Texas and Illinois and Florida. Those are, where they're writing a lot of scripts for PrEP. What I added was one more little star up there in Massachusetts, because they have the highest percentage of their population is on PrEP. It's not the greatest number of prescriptions that have been written there, but their population has the highest percentage on. And those were numbers as of 2015, I should add. So I wanted to throw this slide in here. Do the little takeout here. So this is one of the hookups sites that people use to hook up, and you can see that PrEP is being added as to their status. So see, this person is negative and they're on PrEP. So they put it as part of their profile, and so people are learning about it like that. If they don't already know about it, it piques their interest and says, what's PrEP, So as people learn more about it and as it becomes more common, providers are going to be, having people come and say, I want to be on PrEP. And I'm curious, can I kind of stop here and just see who you guys are a little bit and what your practice setting is? I'm a little bit curious if we can say what the practice setting is. Come in. Hi, come on in.
So we're from Blue Mountain Clinic, and that's a family medicine reproductive clinic.
Okay, are you having people come in and ask about PrEP?
Yes.
Okay, okay. And you have primary care providers, or do you use nurse?
We have family physicians, nurse practitioners,
Okay.
physician assistants, and we all do that.
Okay, and you're familiar with PrEP, that's good. Okay, anybody else? What's your practice setting? You guys, are you with the clinic or?
We're the pharmacy students.
Oh, okay.
We're actually all at
Oh, that's good.
sites right now.
Yeah, that's great.
Yeah, I just graduated pharmacy school, but I'm gonna work in California, so.
Okay, okay.
We're from Greenville, so we're from this.
Oh, okay. All right, good. Well, we just expect that, the reason that I ask is because a lot of times I think there's a thought out there amongst providers that sometimes that they're not the ones that will be dealing with PrEP, and that it would be more the infectious disease docs or the HIV docs that will be dealing with it, but that's really far from the truth. And it's the those family practice docs and the PAs, the people on the front line, those primary care providers that are going to be needing to manage these people, because like Dr. Malloy was our physician in our Ryan White clinic, and we can only send people that are HIV positive to our Ryan White clinic. And so people would have that misconception, oh, you could go to Ryan White, and get on PrEP, but Ryan White can only take care of people who are HIV positive. So this is really, they need a primary care provider to follow these people because it's prevention. So it's a huge misconception, and if you guys can spread that word, like primary care doctors need to know this, they just don't know it yet. They don't realize it. So the goals of PrEP are basically, of course, number one is to prevent HIV infection, and also to prevent the morbidity and the mortality and the cost to society and to individuals in general. John and I were talking about this a little bit, and we kind of looked it up, and what we could find in our quick little research was that costs about $380,000 to take care of one HIV patient for their lifetime. Of course, that's just an average, because some it's more than others, but $380,000. And this being on PrEP is for a defined time, of just when they're at increased risk. The cost is about $1,500 to $1,600 a month. Plus you'd have to figure 4 doctor visits a year and some lab fees in with that. But that's a huge decrease of cost for PrEP versus taking care of somebody that acquires HIV for the rest of their lives. So I think that's really important to think about. So the rationale for PrEP, the reason that they even thought about doing the studies for PrEP were based on 2 studies. One had to do with perinatal transmission of HIV, where they give antivirals to pregnant moms who are infected before the birth of the baby, and then continue antivirals after the birth of the baby. And it has significantly reduced the number of babies that acquire HIV infection during pregnancy and through the birthing process. And so that was one of the things that made them think, I wonder if we could, give antivirals to somebody that's not infected and it would prevent it. And then the other one was a post-exposure prophylaxis study that they did, where they were able to prove that if healthcare workers received post-exposure prophylaxis within 72 hours of having an exposure by like a needle stick or a splash from an HIV infected person, that if they gave them antivirals for 28 days after the exposure, they could prevent seroconversion in those people. So those 2 studies were kind of the basis for them thinking, hey, maybe we could do this. Maybe we could give medication before somebody's infected and have it prevent infection. So that was the basis of the studies. So they went ahead and they started doing studies on it, and they selected Truvada as the drug of choice for these reasons. They knew it was potent against all serotypes of HIV. It was safe and effective, and it was easily tolerated by the patients, so there weren't a lot of side effects or anything. It's really easy to administer. It's 1 pill once a day, and so that's really great. It doesn't have very many drug interactions or food restrictions or anything like that. And then they had done studies on animal models again, and as PrEP, and those showed it was effective as well. So safety and efficacy, when we talk about that, these are the main studies that are cited on it. The first one is the Partners PrEP study, and that was of discordant couples. And so that's one person is infected with HIV and the other person is not infected, and they're a couple. So they studied those in the Partners study. The TDF2 was heterosexual men and women that they studied. And then the IPREC study was of men who have sex with other men, MSMs. And then the FemPrep study was on women, and the VOICE study was on women. So this shows just the efficacy. So 75% effective in this cohort, 63% effective in our heterosexual men and women, 44% effective in MSMs, and 6% effective in women, and none from the VOICE study. So that looks kind of goofy, doesn't it? It's like not great. But the important thing is when you add in adherence. And so when you add in adherence, the people were actually taking the pills, then you get a much better picture of what happened. So it was 90% effective when the people were taking the pills, 78% effective when they're actually taking the pills, 92% effective when they're taking the pills, and then adherence in both of these studies was terrible. It was awful. They just weren't taking the meds, so it wasn't effective. I don't know if they thought it would just kind of seep in from the bottle over to, I don't know what they were thinking. But anyway, this slide just shows basically what that would tell you, is that as you increase in adherence to the regimen, the effectiveness goes up. So you can see there's one other study in here, the Bangkok study that I didn't mention earlier. This was a study that they did on IV drug users. So we've got that in the mix as well. So as adherence goes up, efficacy goes up. And then this one, this slide throws in the voice and the PrEP study, and it basically says if you don't take the meds, you don't get protection. If you do take the meds, you do get protection. So this is how the PrEP study kind of lined it out, is that if a person is taking 7 pills per week, it's estimated at 99% protection. 4 pills a week, it's estimated at 96% protection. 2 pills a week, it's estimated at 76% protection. So those are pretty good numbers. You know, so, and what that shows is that you can miss a dose now and then and you would still have some protection. We really want them to adhere to their regimen. That's really important. We want to stress that every time that we meet with the people, you know, and assess how they're doing with taking their meds. But it is okay for them to miss a dose now and then. So, and it can still be effective. So what they found is that adverse events were very low. There wasn't much difference between the people that took Truvada and the people that took the placebo as far as adverse events. It was well tolerated. The most common side effect is gastrointestinal kinds of illness, you know, nausea and a little bit of, they might have some diarrhea. Those are the most common, and they usually resolve after about a month of taking the medication. So, and they did find that there was a small change in bone mineral density, that it can decrease it a little bit, but not so much so that there were any fractures or noted. So this is kind of by the effects by the numbers. 1 in 10 will probably have some nausea. 1 in 100 will experience some bone mineral density decrease. And 1 in 200 may have some renal insufficiency. So in 2014, the CDC published guidelines for PrEP. This is what the cover of it looks like, and if you want to Google it, then that has everything that you'd want to know about it pretty much. There might be a few new things since 2014, but it's pretty comprehensive there. So if we get to who should be considered for PrEP, what they want to say is that there are 3 categories they break it down into. So men who have sex with other men, heterosexual men and women, and IV drug users. But that's just like everybody, right? So the important thing is, you can barely see it, it doesn't show up here. So it's those who are at substantial risk in these categories, because we're not going to give every single heterosexual couple, you know, Truvada. Just isn't necessary. So what you have to do is determine who's at substantial risk.
The community, I think that's missing out there, part of that I would add would be the transgender community, particularly in some of the cities where there's a lot of
yeah, and I think they
and sex work that's occurring as well. So.
I think they could easily be put into those top 2 categories, you know, just because of how they define what substantial risk is. So, and the principles are really pretty much the same between those categories. So, the way that they do this is that they have criteria. If you're just trying to figure out who's at substantial risk, you know, who should I really consider? So the way they do it is that all 4 of the top criteria need to be met. And it's the same in the heterosexual community too, basically, is an adult, they have to be HIV negative, and that's across the board. We don't want to give Truvada to somebody that's got HIV infection and not, that would be under treating them if we didn't give them additional meds, so we don't want to do that. So if they've had any male sex partners in the last 6 months, so they're sexually active, and they're not in a monogamous relationship with an HIV negative person. I mean, if they're in a monogamous relationship with somebody that doesn't have HIV, they're not going to be at risk if both of them are monogamous, right? So, but if they meet those criteria and then they have one of the following, that would be considered a substantial risk. So if they've had any sex without a condom in the past 6 months, if they've had another STD diagnosed in the last 6 months, that would be substantial risk. And if they're in an ongoing relationship with an HIV positive partner too. So, and really that's what we see the most of, probably the most of our patients that are on PrEP are partners of HIV positive people. That's probably the most at this point, but it's changing. We're getting a lot of men who aren't in a relationship with an HIV positive person requesting it now. So for heterosexual couples, again, the same, it's basically the same 4 criteria. They have to be an adult. You have to establish they are not HIV infected. If they're sexually active in the last 6 months, and they're not in a monogamous partnership with an HIV negative person. So, and then at least one of the following. He could be a man who has sex with both men and women, or they could be not using condoms. And if they have a partner, and that partner is at increased risk, a high risk person. So, or if they have a HIV positive partner too, then you would want to consider them at substantial risk. And then for the IV drug users, it's again adult, no HIV infection, and if they're using. And then if they're sharing any of their drugs or equipment, their works in the last 6 months, if they've been in a drug treatment program in the last 6 months and they're using now. So you would consider them at substantial risk. And if they have sexual risk behaviors, you would want to consider them too. The problem that I see with putting IV drug users on PrEP is that they're really hard to get them to adhere to their medication regimen. They're really hard to get in for their visits because they have to come back every 3 months for a visit and have labs done. And so that's something that you really have to consider when you're thinking about putting an IV drug user on PrEP. Are they going to be adherent to their medication regimen, and can they really come in for their appointments and their lab work? So to summarize, you want the person to be at considerable substantial risk for HIV infection. You have to make sure that they have a documented HIV negative test before prescribing PrEP, and you might have to do a viral load if they've had recent risk behavior too, because you don't want to give PrEP to somebody that has newly acquired or acute HIV infection, so you don't want to miss that. So if you're going to use a test that has a window period on it, you want to know what kind of behavior they've had in that window period. Have they had any risk? If they have, then you would want to consider doing a viral load just to make sure that they're not HIV infected. Because again, giving just Truvada to an HIV positive person would not be a good thing to do, because they could develop resistance and they would be undertreated for their HIV. You want to make sure that they have normal renal function, and you also want to document their hepatitis B status. And that is important. You can give Truvada to hepatitis B positive people, but you need to know that Truvada is active for treating hepatitis B. And so if you're treating hepatitis B, you don't want to just take them off of those meds when their risk is over, because they could have a flare in their hepatitis B. So you wouldn't want to unknowingly be treating somebody for hepatitis B, because that needs special management too. So you just have to make sure that they're not hepatitis B infected as well. And then if they are, you might want to consult with your hepatologist on it. So you want to make sure that they're able to comply with their medication regimen, that they can take one pill once a day and be adherent to that, and that they are willing to come back for their 3-month visits and follow up. So those are kind of the important criteria. For prescribing PrEP, these are basically the steps that you want to go through. You want to determine their eligibility per those, are they at substantial risk? Is this really a person that's a good candidate? You want to know if they can take the pill every day, can they follow up with their regimen. You want to screen them for HIV, consider doing a viral load, just like I said. Check their hepatitis B. You want to do hepatitis B surface antigen. Is the most important one to see it, or you could do a surface antigen, antibody, and core would probably be a good panel to do. To prescribe PrEP, you just want to write the script for Truvada, 1 pill once a day. You can only give them 90 pills at a time, and then they have to come back every 3 months for a refill. And then at every visit, you want to really stress the importance of adherence. And you want to do continued counseling, make sure that they're not thinking that this is something that they don't have to use any other protection for, because if they acquire another STD, they are more at risk, increased risk of acquiring HIV if they come in contact with it. So it's really important. If they've got gonorrhea or chlamydia and they're exposed to HIV, the chance of contracting it is much greater. So just really stress that it isn't a standalone strategy. They still need to be using condoms and other methods. Labs, again, are every 3 months. You want to do an HIV test. Every 3 to 6 months, do STD testing. And I just was listening to one of the docs from Harborview talk about this, and he thinks every 6 months is insufficient. So he's going with every 3 months doing the STD testing, because he thinks it's too long. If they did get gonorrhea or something, it's too long to let them go, without testing 6 months. So why not, if you've got them there, just do gonorrhea and chlamydia. Throw in the syphilis testing, because we're seeing an increase in syphilis activity, which is pretty alarming.
And not necessarily in our, just discordant monogamous relationships. I would.
Yeah, if they're monogamous and it's just discordant couples and they're really being monogamous, but they still do recommend STD testing. You might be able to put it off every 6 months at that point, but those are the guidelines. So,
do you want to do pregnancy testing?
I would think yes, that you would do a pregnancy test. They don't detail that, but yeah, I would think you would want to. So, and you need to check their renal function at 3 months, and then after the first one at 3 months, then you can change it back to every 6 months for their renal function tests. And the guidelines recommend that you do check their renal function per the Cockcroft-Gault calculator. You can just Google that and it pulls it up, and you enter in the creatinine, the serum creatinine, their age, the sex, and I think their weight. and it will calculate it for you. You want them to have at least 60 mils per minute of creatinine clearance. So that's important. And there's some other calculators. This one is the one that the guidelines says use this calculator, but some of the other physicians out of Harborview say that there's some better ones that they might recommend that pull in a little more data so you get a little bit better thing. But if you have any reason to suspect that they might have some renal insufficiency, you really want to calculate this out, and they should meet this criteria. So, discontinuing PrEP, you want to reassess the need for PrEP every 12 months. You know, the life circumstances change, and people that were at risk might not be at risk anymore because they have made life changes. So you just want to reassess that every 12 months to see if they're still in need of it. Some reasons that people might discontinue it are they might be having side effects from their meds. They say they're not at risk anymore. Maybe they're not adhering to their medication regimen, and you want to discontinue it because you have concerns if they're not adhering to the regimen and they're putting themselves at risk, if they're only taking it once in a while or episodically. It is not approved for episodic use. They are doing studies on that, but it's not approved for that. And so there is concern about if they did get HIV infected, then they might develop some resistance to the meds. So if you have a patient that does discontinue PrEP, then you want to document their HIV status upon discontinuation. Write a note about why it was discontinued, and then if they ever want to start it up again, you got to go through the whole rigmarole at the beginning again. Okay, so this is the part that I think people view as barriers. Medicaid will cover the cost of PrEP, and Gilead has a medication assistance program for people that don't have insurance to get it through them. And then they also have a program for co-pay assistance. And we've had a couple incidents where I don't know, it must have just been some kind of administrative errors or something. One patient in particular, he went over and they said it's going to be, I think it was going to be $900 copay or something for the month. He's like, I can't do that, but it was a mistake. And so really nobody should have money be a barrier for it, because these programs are available, and really most all of the people that we have on PrEP are not paying anything out of pocket. So if you're running into that, you just pursue it further. And Carissa Hurst is our medication assistance program person who does most of ours. I'm sorry, have you been able to see? She said that I could put her phone number in here, and if you have any questions about it, if you're having issues with it, she's happy to help you with it. And there's the website where you can get the assistance through Gilead too. So hopefully that won't be a barrier to getting your patients on PrEP.
Will Gilead pay for the doctor's visits and the labs?
I think it's mostly just for the medication. So I would think that there would be other kinds of programs for, medical care and getting the labs taken care of. I know our clinic, we do a sliding fee scale for people, and if they show their income, then we bill them based on that sliding fee scale. So there are some options to help people with that.
And in our town, there's no one from Partnership right here at the residency, but the residency is doing, and Partnership is doing PrEP. So if you have that person that needs sliding scale for that, they they're doing PrEP pretty regularly. They're asking their patients about it. There is a clinic here.
Yeah, partners. So I added this in, and this has some of the billing codes, the ICD-10 codes that can be used. The ones that we're using most commonly are providers, or just these: high-risk heterosexual behavior, high-risk homosexual behavior, and high-risk bisexual behavior. And then if you have an IV drug user, it's just IV drug user. So that would be how to code it for billing. And I just wanted to throw this one in. It shows some of the methods that are being developed that are in the pipeline. They've noticed that there are a lot of cultural differences between people groups, you know, of what they like and what is acceptable to them in their culture. And so they don't want it to be a one-size-fits-all. They're trying to make it available to something that would fit the lifestyle of, you know, a lot of different people, you know, and you would have a choice. But these are some of the things in the pipeline: an injectable vaginal ring, vaginal film, gel, and then of course we have the pill. So I think that's it. I think we did okay time-wise. What time is it?
12:44.
12:04. Oh, we did pretty good. So yes.
So I think Pam showed you an article we found, but it's from a professional journal called Contagion. It's from last month, and they did some testing where they had some patients, and they're saying that PrEP is 44% effective. They did serum testing and pharmacy record reviews that both support that the patients are 100% compliant with taking their PrEP. And the theory is that the virus is mutating and PrEP is going to be decreasing in effectiveness.
Pam showed me that article. I hadn't seen it before. The information that I had was just from last November, so it's been, you know, 6 or 7 months ago. That was when the second patient had acquired HIV, and at that time they were thinking it was not due to, that it was due to non-adherence. So I don't really know. I just saw that article. I'll have to look at it.
Yeah, so what this article is saying, this is the third patient, and they were compliant because they did the blood levels, and it showed they were taking it. The guy said he was taking it. Pharmacy said he was coming and refilling, and he still came up HIV positive, and they're saying it's a drug resistance now.
So it might be that the source patient, I don't know if in this instance, if the source patient had already developed resistance to Truvada and then passed a resistant strain on to that person. I mean, that could be an explanation for it, but I can't say for sure because I haven't read the article. But you've read more than I have on it. So.
Yeah, and this just came out. This is real like 2 weeks ago.
Yeah.
That'd be a relatively easy thing to study in a major center because every newly infected HIV patient who comes for care gets a drug resistance test. That's part of the initial workup.
Yeah.
So those patients should, it should be easy to track, over a large number of patients. Truvada in the past, I think, has been fairly good in terms of having some barrier to resistance. Has been very effective. I had a patient that came to me from St. Paul, Minnesota, and she'd been on just Truvada for a number of years, and she had some fear about being on a three-drug regimen, which was what she should have been on at the time. And I thought for sure when I tested her that she would have drug resistance, and she had none. So I was quite surprised about that. But it does have a fairly high barrier to resistance, and that'll be an interesting study to be able to do in a big center, is to pick up on these patients that appear to have failed PrEP, and when they come in for care, get their drug tests and see. The only thing that might cloud that a little bit is that the meds have been around for so long that there's quite a few resistance mutations in the infected population. So you might be picking up somebody that got a drug-resistant strain from whoever infected them. And we did see that in our practice over in Billings from time to time. It wasn't common, but it does happen. But anyway, so that's an interesting, it's interesting that they picked up on that because it is a concern.
Well, that's the hardest part for us too, is adherences. So we have people that have come in and we've made it so that they can even, it's just a simple nurse visit. And if they can't afford their HIV test, then we give them other screening places where they can bring us just the paper of the HIV test. And so we've tried to make it like everything as easy as possible. And so they don't even have to wait for a doctor's appointment. They'll always be able to get in. They'll always be able to get their blood test done without us. And how can we get them the cheapest? And we still have people that like will come for 1 3-month round, and then they'll kind of come another month later. And by that time now I'm kind of having to restart with a viral load again, which becomes more expensive. And wait the 2 days till I get my viral load back, and then so that's we're really having trouble with that adherence part, and we are trying to, like, we made it to break like every barrier to make it easy to come in and get your, you don't have to keep seeing me, you don't have to, you know.
And we have denied putting people on PrEP that wanted it, that we really just thought cannot adhere to that regimen and the requirements, which is sad. You know, you want people to be on it, but I think if they're not going to be adherent, you know, then they really do set themselves up, I think, for some of these issues that could come up.
Like getting HIV and then
being under, and well, getting HIV, not knowing it for a while, and taking Truvada sporadically, and then developing some resistance because of the sporadic, you know, use of it. So
it is interesting how big of a problem adherence is. You know, the patients that we were seeing have been retired for about 1.5 years, but over the last, maybe 5 or 6 years or so, the patient comes in, you work them all up, and you say, well, you have HIV or you have AIDS, and here you are, 1 pill once a day, nothing to it. You know, you just go ahead and take your meds and you'll be fine. But even some of those folks have trouble with adherence. They'll miss their meds and stop taking them for a couple of months. And I had one gentleman come in that was just, he was my star patient. You know, he had a CD4 cell count of 9 when he turned up, and we got him started on medications, and he was doing just great, and came to the office, yes, Dr. Molloy, I'm really doing good, I'm taking my meds, and then he comes back with a viral load of 35,000, you know, what happened to non-detectable. And I had him come back, I called him, he was a real nice fellow, and he said, I'm sorry, Dr. Molloy, I said, I lied to you, I was having headaches on meds, and I quit taking them. Well, it was 3 months ago. So, you know, you just never know. But drug levels would be real helpful. But they're expensive and hard to get. But if you were looking at patients and you're worried about adherence with PrEP, if you could do drug levels, could afford to do them, that pretty well proves you're taking the meds. I hope that answers your questions. It's interesting.
So one thing I was wondering about, so obviously when you see the patient, like a new patient is trying to provide, is there a time period for which, you know, they have to be on it before, let's say, we can engage in aggressive behavior, and we can be sure that medication will be effective, like you just say, take this for a week and you go, or is it like that day, obviously?
it's about a week. Yeah, you want them to be on the meds and get their blood level up to, it takes about a week for them to get to a point where it's going to provide protection for them. That's the recommendation.
I was going to make one more comment about the STDs. Kim mentioned a lot about, you know, the importance of checking for STDs every 3 months. And the reason that's important is because STDs enhance the transmission of the HIV virus, and you want them not to have, you know, gonorrhea or chlamydia.
Any other questions? Any observations or experiences with people that you want to share?
I just would say in Montana, in Missoula, when you're working with a trans population, just ask very clearly, you know, do you have a penis and where does that penis go? Do you have a vagina? What goes in the vagina? Do you have, you know, like talk very matter-of-factly, don't, because the male-female terms get very confusing with the population that has not had reassignment surgery and who their partners are. And so you just need to be very open and honest about figuring out their risks rather than just making assumptions about what sexual acts they're engaging in. We forget sometimes because we're maybe seeing someone who isn't really there for their transmedical issues, and we might not know what their anatomy is. We might think we know what their anatomy is. And so.
Well, and it's always super important for when you're doing the STD testing to do that really good sexual risk assessment, you know, to ask those exact questions of anybody that you're testing for an STD, because you're not going to know how to appropriately test them, which orifice to test if you're not asking where you're having sex. Are you having oral sex? Are you a receptive partner? Are you an insertive partner? You know, to be able to test the person properly, you need to know those things. And so really getting providers to be comfortable with asking the questions and doing a really good sexual risk assessment is really important too. So otherwise you'll miss an STD. So anything else?
I just wanted to thank everyone for coming. I'm over at Open, and so we do the rapid test. And sometimes, you know, if I'm making a PrEP referral and it's someone that wants to stick with their primary care, I'm constantly telling them, you might have to be educating your primary care doctors. Because I've heard so many stories of like, well, I asked for PrEP and they said that it wasn't labeled for that, or that they couldn't prescribe it because they weren't, you know, a specialist. And so
That's been my experience too, and it's really difficult to get those primary care physicians educated that they are the ones that need to be monitoring these people. It's prevention, and they need a primary care doc to follow them over time. They don't need an infectious disease doctor. They don't need an HIV doctor. You know, they need a primary care doctor that can provide the meds, do the follow-up, do their routine testing and lab work, and prescribe the meds. So really, if you guys can help educate people, because really they think, oh, we don't need to know that. It'll be done by somebody else. But we've had a few people, you know, just the populations they're getting smart about this. And we had one guy that sat on a panel with us, and he said, I went to same-day care. I'm like, I want to get on PrEP. And they're like, what is PrEP? So they didn't even know what it was. Fortunately, he had taken some information in with him, and then he got referred to an infectious disease doc, which isn't necessarily the right referral, but at least the referral happened and he was able to get on PrEP. But those frontline people, maybe the same-day care people, aren't the ones that would monitor them over time, or the ER doc even, but the ER docs need to know about it too, because if they have somebody that comes in for post-exposure prophylaxis, then they need to be equipped to say, but I think you need to be on PrEP. When you see those high-risk people, to just be able to make the referral, you know, somebody goes to the ER and says, I had sex last night with somebody and I found out they're HIV positive. Then it's post-exposure prophylaxis, and you know they're going to go to the ER for that, or the same-day care, and they need to get on meds. But then that's a good opportunity to talk to that person about getting on PrEP. So,
In defense of the primary care providers, a lot of times they're really busy and stressed, and somebody will walk in with something like that that's really kind of coming at you from left field. You just put your hands over your head, so I can't deal with this today. But if you send the guidelines with your patient, you might have a better chance of getting started on it, you know.
definitely.
anything else? Well, thank you for coming today. We really appreciate it. And if you could take time to fill out the PIF form and the evaluation form, we would really appreciate it, and just turn it in before you head out for the rest of your day. And there's still some food back there if you're still hungry, so please help yourself.